Getting ready to. This is a 2-level lumbar Deuk laser disc repair for 2 herniated discs, L4-5, L5-S1. Patient has back pain from the discs that are herniated and leg symptoms. I'm going to give you some numbing medicine, okay? You'll feel a little stick and burn. If you feel pain, just let me know. Our patient is awake for the beginning of surgery. We're going to put him to sleep shortly, but I have to give him a a little numbing. Sorry about that. I know it's uncomfortable. Just give it a second. It's gonna feel better, okay? If you have questions throughout the surgery, type them up in the dialog box. We're streaming these live on YouTube, Facebook, Twitter, and LinkedIn. We'll answer your questions for you at the end of surgery. If you feel pain, just say ouch, and I'll go ahead and give you some more numbing medicine, okay? Try not to move around, though. Shot? We got way too much sacrum being shown, okay? You need to be further north. Shot? That's much better. Even a little bit more north. And then get that 5-1 disc lined up. It's close. You see the pedicle of 5? You're very close. You're probably a degree at most, half a degree maybe. All right. I'm going to be a little bit more north than where I am. So the first part of the surgery is what we call localization. We want to find the place where we're supposed to operate. Can you help me out there, or are you? Oh, here. You want to see? No, I mean reduce it. Reduce it. Shot. All right, that's better. Everything okay? Ladies, none of them? So the first step in the surgery, if you want to know technically the first step, it's to bring the patient in the operating room, position them on the table, and then prep their back and drape them. So we want a sterile field. These surgeries are done under sterile conditions, so there's no bacteria introduced or fungus is introduced into the body. Our patient is sterilely prepped and draped. And the next step after that is going to be localization, which means we gotta figure out exactly where the place to fix is using an X-ray machine. Some more local. For the skin. And we do that using the X-ray machine to find a starting point. The starting point is going to determine our trajectory to the target. The target is the herniated disc. So a starting point is placed somewhere on the skin. The target is the herniated disc. And to get to the herniated disc, we have to enter somewhere, and that's what I use the X-ray machine for, is to figure that out. We call that navigation. Shot? How is he doing? Comfy? There's the facet. So I want to be a little bit more anterior and north. Shot. Are you comfortable? Shot.
Doing all right, sir?
That's it right there?
Yes, sir.
Wow. Shot. So I'm banging up against the facet joint, which means I need to redirect to a little bit more anterior. Shot. I like my lateral trajectory. It's just shot. That's better. Shot. Shot. So I need an AP. I think we're off a little bit on rotation, just a little bit. Let's just go for an AP first. I want to avoid being too medial, which means too much towards the midline. And I want to avoid being too lateral. I think, if anything, I'm a slightly lateral, but not bad at all. I'm going to try to redirect and go a little bit more medial. You doing all right, Luis?
Yes, thank you. How can you see?
Huh?
How can you see?
I have eyes everywhere. I'm part reptile. Shot? Oh, really? Do we need to do 2 piriformises today? That's really good. I like that. Are you comfy?
How you doing, my friend?
You all right?
He said yes, thumbs up.
All right. Let me know if you have any pain, okay? You're doing great. Surgery's going well so far. We're almost done with the hardest part, which is getting to the disc. Nothing?
Any pain, sir?
What's he saying? I can feel the herniation right now. So I went right through the tear into the L5-S1 disc. Now, compare that, for those of you that watched the surgery before, compare that. L5-S1 is the hardest disc to get to. We just got in there. It took us less than 5 minutes. 5 minutes maybe. And compare it to the last procedure where we tried for an hour and a half. And that wasn't lumbar, that was thoracic. Okay, so you can see, you know, depending on the patient's anatomy and the level you're trying to get to, there's a huge discrepancy in access, you know, getting to where we need to be to do the surgery. I need a Raytech. Thank you, Luis. So you doing the piriformis dance, Luis? All right.
You need a pillow. I did it already, and it feels much better, actually.
Good. Well, if you need to sit down, feel free. Shot?
I'm good.
You're a good man, Luis, and I appreciate everything you do. Shot?
I do too. Huh?
Yeah, I think we all do. We all do. Shot? You know, it's impossible to do this complicated surgeries without really good help. And I've been challenged but blessed at the same time over the years. Are you okay?
How you doing, my friend? You all right?
All right, I can
You
feel
have
the
any pain?
facet
He
once
said
again.
thumbs up.
All right, we're almost done. Shot?
Does he have a little spondylolisthesis there?
He's a little spondylolisthesis, you're right, but only maybe 5 millimeters, nothing worth fusing. All right, so at this point, are you okay?
Thumbs up.
All right, our patient's awake, comfortably laying on his belly, and we've now done the hardest part of the surgery, which is to go from the outside world into the disc that we're going to fix. There's 2 discs we're going to fix. The first is L5-S1. All right, I'm going to draw the disc right here, and then there's the L4-5, okay? Now, when I asked him in the clinic, where is your pain? He told me it's in this area right here, okay, this box, pretty much. And I knew from the MRI we had a few discs in there that were abnormal. They were damaged. But check this out. There was also a disc up here and also a disc up here. And I asked him, do you have any pain in this area up here? He said no. So basically his pain was lower in his back and only over L4-5, L5-S1. So even though there are 4 herniated discs, only 2 of them are causing pain. So the first one we're going to test, well, I won't say which one it is, but I'll tell you in a moment. And then this is the L4-5. And by the way, I'm not really left-handed, but I'm writing left-handed. Okay. Once we've gained access to the disc, we've navigated into the disc, the next step is to verify that these are the cause of his pain. How long have you had back pain?
How many years?
When did it start?
7 years.
7 years ago.
That's even longer than that. You said longer than 7? 7 months, not years. 7 months.
7 months.
Sorry.
Before that, did you have pain in your back ever before? Well, it's either yes or no.
Said no.
So before that, you never had pain?
No.
No. All right. There you go. So he's had his pain for 7 months. And where did he travel from?
Rhode Island.
Rhode Island. All right. Very good. So our patient is from Rhode Island. Are you comfortable?
Yes. Thumbs are up.
You can see his whole body tense up. How bad is that on a scale of 1 to 10?
0 to 10, buddy. How bad?
What's the worst it got?
Give me a number. Huh? 9.
9. Is that where you typically get your back pain?
Said yes. That's what
All right. So he had, I'm going to write it down.
9 out of 10. Concordant.
9 out of 10 concordant for those of you watching. That was L5-S1. You could see it on the x-ray. So this was a 9 over 10. We put a C for concordant. What does that mean? Concordant means that is his typical pain he gets every day. See, if somebody is hurting in their back, but we create pain that during the discogram, but that's not their typical pain, well, then that's not what we're targeting, right? We don't want to fix something they don't normally have. So we want to fix something they normally have. So I'm very happy to report the lower L5-S1 is a 9 over 10 concordant. Are you better now?
Yes.
Any pain?
No.
Okay, he's comfortable. Okay.
Yep.
See that? He jumped up. How bad is that on a scale of 1 to 10?
0 to 10. 9.
He's pretty tough. Never a 10. He's a 9. Another 9. So this disc at L4-5 is also a 9. You want to start with 4-5 or 5-1?
That's a 5. I'm sorry.
No problem. So this second disc is a 9 out of 10 pain, which is really, really bad. You could actually see when I injected it, he kind of, like, his whole body tensed up. That's because when you do a discogram, if people have a painful disc and you're doing a discogram, it will elicit that pain. So I'm very happy that we reproduced the pain. Now I know that pain will be gone. That pain will be gone when you wake up, okay? All right, you get to go to sleep now. I want you to count out loud from 1 to 100. 1 to 100 out loud so we can all hear you. Start counting. While he's counting, we're going to put him to sleep. Keep going. If you make it to 100, I don't pay the anesthesiologist today. So count a little faster for me. I'm just kidding. Of course we will. Dr. Berndez is worth it. Okay, so the guide wire's in. Now all I got to do is use this dilator to run it down the guide wire, and it's going to spread apart the muscle and fascia, and then it's going to end up right where the herniation is, and that's where we go into the disc where the herniation is. Why is that important, folks? It's important because every other surgeon out there is going to do a surgery on you where they're going to make a huge cut on your back. They're going to destroy your fascia and your muscles by scraping it off your spine, damaging those muscles forever. And then they're going to remove the bones and ligaments from your spine just to get to where the herniation is. That's an old-fashioned way of doing it. So the way we're doing it is called transforaminal. It was developed by Dr. Parvis Camben in Pittsburgh. He was a professor of orthopedic surgery at the university, and he taught it to a few surgeons from around the world who came to learn from him. I was not one of them. That was the generation before me. I learned from those surgeons because I was still in high school, I think, at the time. So by the time I got through my residency in neurosurgery, there was already another generation of surgeons after Dr. Camben who learned his transforaminal technique. Now the problem with Dr. Camben is that he actually, take it out, he had a lot of complications, okay, from the surgery. Let's face it, he had a lot of complications. And he basically, most of his students could not do the technique. But what happened was, of, let's say, 50 people that learned it from him, about 5 of them, 10% of them, actually learned it in such a way that they were able to modify it a little bit and get better results. Now, there is some secrets to getting great results to do this surgery, and I've learned them a long time ago, and I've been using them every surgery I do. If you watch carefully in my videos, you can see what I do. But ultimately, I have to train somebody to teach them all the secrets. Without those secrets, you're going to end up hurting a patient. And you'll have results like Dr. Camben, and the patient will not be happy. Okay? So to have great results, you have to do the surgery perfectly right. Shot. There's only really one way to do it just right, and that's called the Deuk laser disc repair. If you don't do the Deuk laser disc repair technique, then you're not doing the surgery the right way. Shot. Okay, so you can see the tube is inside the disc, and it went right through the tear where the herniation comes out. So we're going to basically start our work in the innermost part of the herniation, right at the start of the tear of the annulus fibrosus. Remember, the annulus is the outer wall around the jelly that holds the jelly in place. It's about 2 centimeters thick, and where we are, it's maybe 1.5 centimeters to 2 centimeters thick. So we're going to start at the innermost part of that tear and remove that herniation from the tear. Okay? This is going to take us about 10 to 15 minutes to do. While I'm removing the herniation from the tear, I'm also going to clean the tear so that it will heal properly. Okay? It's called an annular debridement. Now, the annular debridement was something that I pioneered at Deuk Spine Institute about 16 years ago, back in 2006. We've been doing the Deuk laser disc repair now for 16 years. There's been 0 surgical complications. We've never had a nerve damage, spinal fluid leak, no infections. Other types of spine surgery like microdiscectomy, laminectomy, complications are quite common. Flynn, why don't you show our audience with our animation video what causes back pain when you have a herniated or bulging disc? By the way, before you run it, there's something you all should know, and that is that there's many different names for herniated discs, okay? Small ones are called bulging discs, but they're still a herniation. They call them protrusions, ruptures, extrusions. There's so many different names, but in the end, they all refer to the same thing, which is a tear in the annulus and a herniation through the tear. The disc is actually quite simple in its structure. Therefore, there's not many, variations you can do. It's like if I gave you a hot dog and a hot dog bun and said, make a meal from a hot dog and a hot dog bun. There's not much you can do. You can, put the hot dog in the bun, or you can cut up the hot dog, or you can cut up the bun. But in the end, there's only a few variations. So with a disc herniation, you only have the annulus and the nucleus. So why so many different names and terminology for just 2 little things, like a hot dog and a bun? And the answer is, I don't know. I don't know why over the years they've developed so many different ways to say a hot dog and a bun. But for some reason they did. All right. Well, we're getting started now. Now, visibility is not great, Luis.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Oh, we're back. All right. Are we back, Flynn? All right, thank you. Welcome back. I don't know how much of what I said you guys heard, but we were just talking about, one thing that confuses people out there is all the different names that a herniated disc has. Protruding disc, prolapsed disc, extruded disc, bulging disc, ruptured disc. Those are to name a few. The reality is they're all talking about exactly the same thing. And to tell you what that is it's a tear in the wall of the disc called the annulus. And that tear is called an annular tear. Through the tear comes the jelly from the center. So it's just like opening the cap of a toothpaste and then squeezing the tube. Well, the toothpaste is coming out. Hey, Monica, can you just pay attention when I get the laser back in, please? I know. Do me a favor and just kind of focus on the laser part. So all of these, I know, I'm mesmerizing. My voice puts people to sleep. That's what my wife says. And I would honestly prefer just to shut up and do my surgery, but the reality is people won't understand everything I'm doing, but more importantly, I lose the opportunity to teach people while I'm here. So I talk to teach.
Future of surgery today.
And Dr. Berndes says the future of spine surgery today. That's what you're watching. Mm-hmm. So what do we mean by that? Well, what we mean is that endoscopic surgery, like what we're doing right now, is not done everywhere else yet. It's literally going to be done everywhere in the future. But the reason for that is it's such a good surgery. It works so well. There's been no complications. It's safe, and it's very effective. So naturally, over time, there will be a higher adoption of this technology by surgeons and patients when they become aware of it and learn how to do it. But there's a learning period where all these surgeons have to learn this technology, how to do it. They have to be trained, and that takes time. So during that learning period, it could take 20 or 30 years to teach all the spine surgeons how to do this. A lot of the older surgeons, they're not going to want to learn a new technology. So what's going to happen is they're just going to keep doing the old-fashioned surgeries, which is fusions and laminectomies and microdiscectomies, which are very damaging and don't work well at all. People may get some temporary relief right away with those types of surgeries, but then again, the pain comes back later because the surgery itself creates what's called instability. And once you've had a laminectomy, you have to understand the surgeon is removing your lamina. That's a piece of bone in the back. There's nothing wrong with your lamina. Your lamina are perfectly normal. But to get down where the herniation is, they got to take that lamina out. And the way they do it is they use metal instruments to remove it. The Deuk laser disc repair doesn't use any metal instruments to remove lamina. The only thing I'm using a metal instrument to remove is the herniation. So the difference is we don't do any damage to your spine while fixing your spine. Everyone else does. And it's just sort of been accepted that that damage is okay. And that's what spine surgeons believe. They think it's totally normal to damage people's spines while they try to fix one part, they can damage another. So what we're saying with this technology that Dr. Camden developed, this approach through the foramen, is that no, it's not okay to damage one part of the spine in order to fix another. And especially when you now have a way to fix the damaged part without damaging anything else. And that's called transforaminal endoscopic surgery, what we do. Now the problem is in the United States, there's very good surgeons, however, they're not trained on this technology. They're all basically trained to do fusions and artificial discs and some laminectomies. These are older technologies, but there's a force that's keeping them doing that, and that is there's companies that make those screws and rods and cages and plates, and they're paying those surgeons, they're getting those surgeons paid a lot of money to do those types of surgeries, whereas this type of surgery doesn't pay as well. So there's a financial incentive for surgeons to keep doing the old surgeries, and it's very complicated, but I understand it quite well. And I don't want to go into too much detail on it because we've already talked about it before. But that financial incentive in the spine world is at odds with what's best for the patient. What's best for the patient is less invasive, safer, with better outcomes and results. What is an outcome, for those of you who don't know? An outcome is what happens when you do something, right? We call that the outcome. Okay? If you drink and drive, the outcome would be you crash your car and you die, and maybe you kill somebody else along with you. That's a very bad outcome. So that's why we recommend against drinking and driving. Well, a lot of spine surgery done today has very bad outcomes when compared to the alternative, right? Which is endoscopic surgery, less invasive. So what we're trying to do is raise awareness about the bad outcomes of traditional spine surgery and replace those bad outcomes with good outcomes from Deuk laser disc repair endoscopic spine surgery. But the problem is surgeons themselves won't make the change because, again, they're financially incentivized to do bigger, more complicated surgeries that people don't need because they get paid more. So it's really today in 2022, it's going to be up to people like who are suffering with back pain. They're going to have to demand better care, okay? And if you don't demand better care, you're not going to get better care. This patient came from Rhode Island down to Florida for the surgery. And he wants better care, and he's demanding better care. He's getting it. Why? Because he's traveling and he's educating himself. He somehow found out about this procedure online by, watching our videos and reading our website and learning what it is that we do and why it's different and better. Okay? You want me to wait? So as a result of his efforts are paying off. He's not going to have a fusion. Otherwise, he would be having a fusion at L4-5 and L5-S1. Now, here's the problem. Some of you who have been paying attention since the beginning, you remember I told you he has herniated discs as well at L3-4 and L2-3, but they're not causing any pain today. Therefore, they don't need to be treated. And what I mean by today is I mean they're not causing pain at all. Even though they're herniated, they're not causing pain. So here's the thing. Lay still, everything's okay. If we do a fusion at 4-5 and 5-1, I'm just going to wait for you to... If we do a fusion at 4-5, scope off, and 5-1, lay still, you're fine.
Oh, thank you.
What do you think's going to happen at the L3-4 and L2-3 discs? They're going to end up getting more force applied to them from the fusion. They're going to get more degeneration, more damage over time because of the fusion. So this patient will end up having a L4-5, L5-S1 fusion now, but then in a few years he'll have to fuse L3-4, and a few years later L4, L2-3. So basically that's why fusions keep going. People that have a spinal fusion end up with 2 surgeries, 3 surgeries, 4 surgeries or more because those adjacent discs start to degenerate. Let me know when I can proceed. All right. So Flynn, at this point, why don't we run our video animation on the Deuk laser disc repair, how it works, and that way our audience can see what it is we're doing here to fix this problem for him, and how it's a natural solution. We're not doing any metal or any kind of implants in the body. We're just basically cleaning up his tear.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back, and Flynn has been showing you our animation videos so you can understand exactly what's happening with not just a herniated disc causing pain, but also what we do here at Deuk Spine Institute to get rid of that pain. And it really comes down to treating the source of pain, which is the tear in the back of the disc called the annular tear. And that's where all the pain comes from, is that tear. So even though the disc itself may be degenerated, it may look dark, we call it desiccated. Sometimes you'll see that terminology on an MRI, desiccated disc or degenerative disc disease. None of that matters because that's not causing the patient's symptoms. What's causing this patient's symptoms is quite honestly just the this tear that we're cleaning. It's inflamed, and inflammation definitely causes pain. So if you have questions, please type them up for me. I'll be happy to answer them for you guys as soon as I get out of here. And we're going to be done with our part in about 20 minutes. I'm just going to wrap up this L5-S1 disc, and then I'm going to go on to the L4-5. By the way, for those of you who don't know, we have an app on the iPhone and Android. That app is available for free. You're welcome to download it and use it. There's some good teaching in there. You can also ask questions during the surgery or afterwards. I'll answer them for you. Flynn, do you have the questions from the first surgery, perhaps? Did you make note of any questions? Come on, Oscar.
Sorry.
What's that? Uh-huh. So you could go to the YouTube channel and watch that surgery, right? And there would be those questions there. What's that? Well, you have a laptop there, right, next to you? Would you be able to see those questions on YouTube? Oscar, you're not grabbing it properly. Flynn? It doesn't take any time to upload. What would take time to upload, Flynn? Oh, so you're saying it's not on YouTube? Oh, okay. I see. So you're saying from the time you hit end on the live stream to the time the video is available on YouTube, there's a period of time there that could be up to a few hours. Understood now. That makes perfect sense. Thank you for explaining that to me. All right, well, if you can find it, then let's see if we can answer everyone's questions from the last surgery as well, because I didn't get around to doing that, having to deal with some other issues. All right, these are all pieces of herniation. You see the blue thing here I'm working on? That's stained blue, and that's a piece of herniated disc. And it was literally stuck inside the annular tear. And if I don't get it out, then it's going to end up staying in there and causing problems for the patient. So it's important to get all the pieces of herniation out that you can. Now, notice how we can see all these herniated pieces using the endoscope, right? A lot of other doctors, they don't use the endoscope. There's only a few surgeons in the world that do. And the ones that use the endoscope can actually see all the herniation pieces inside the disc, just like we can right now. But the ones that don't use the endoscope, which is 99% of spine surgeons don't use the endoscope, they cannot see these herniations. Therefore, they cannot fix them. If you can't see it, you can't get rid of it. You want to get rid of all these pieces that you can. And only through endoscopic spine surgery can you actually see inside the disc. We are literally inside the herniation and the annular tear right now. All right, looking good. I think we're just about done with L5-S1. I think he's going to be happy with these results. I know I'm happy. Just a little bit more to go and we'll be finished. As far as the age of this herniation, I think, 7 months is certainly reasonable, but I would say it looks older than that. That's fine. I think this injury originally happened even longer than 7 months ago. If I had to guess, I would say it's been years, many years since he had this herniation. But it may have just started really acting up in the last 7 months for him. And that's really very common to hear that kind of a story from patients, is that they have various durations of their symptoms. Oh. Luis, when you test these scopes, my advice is to bend the scope a little bit while you're testing it to see if it deforms. Are you doing that?
I do that more with the cervical one. This one you should not get blur with the bending.
Oh.
Yeah.
Yeah,
The
no, it
cervical, I do
happens.
that a lot, yeah.
No, it happens in the lumbar too. But it shouldn't happen.
Correct.
I agree. So if it happens while you're testing it, it's a problem.
Correct.
It means the glue is failing on the lenses. So, do you think we're having more lens failures because using this more powerful laser? Laser off?
I mean,
I'm just curious. The nerve root's up here in the fat. You can't see it. That's good.
yeah,
It's protected. But we're done with this disc.
Lights off, please. Go off, please. Thank you.
I like to look for the nerve root just to see if it's there. Sometimes we see it, like the last one we did, we saw it. The last case we did on Tuesday, we were able to see the nerve roots, so it's pretty cool. They look shiny and white. And today, though, there's still a lot of fat in the foramen, which is good because fat pads and cushions the nerve root. That's the way it's supposed to be. Dilator. Now we're using a little antiseptic to clean out the area that we're operating on. That antiseptic is iodine based. It's called betadine. Come on in. And betadine was an antiseptic developed by NASA, but it's also used in surgery. In my opinion, it's really the best antiseptic. As long as the patient doesn't have an iodine allergy, they should be fine.
Yep.
We always check for that ahead of time, and patients tell us when they have allergies.
Monica, you can start. Yeah.
Come on in, Monica, come on. We're waiting for you.
Guy wire, Oscar. Thank you.
All right, so we're going to move on to the next disc, which is L4-5. How's our patient doing, doctor? Come on, Monica. You shouldn't even take that shot, you know? You got to lower the fluoro first. Ah. All right, well, at least you're doing the right thing. I appreciate that. Shot. Come on. Pay attention, Oscar. What's that? For what? For what? For what? But that's not what's stimulating him. What's going to stimulate him is right now, going into the disc where the herniation is. That's where it hurts. I don't know if you realize it, but what hurts is the annular tear, right? That's why we're doing an annular debridement. That's the whole point. Shot. All right. Monica. Okay, we're going to get started on the next disc, L4-5. The most common disc to cause back pain is L4-5, and it is causing pain in this patient as well. The second most common disc to cause back pain is L5-S1. The third is L3-4.
Thank you.
Here we are inside the herniation. There's a piece of herniation right there. Remember, when we entered the herniation of the disc through the tear, we actually pushed the herniation into the disc. And that's what we're looking at right here. It's part of the herniation. There we go. It's coming out in little pieces, unfortunately. Now this to me looks like it's 7 months old. This is a fresher piece of herniation, for sure. This is not as collagenized, not as much collagen or scar tissue on it. It feels softer, and this is definitely a fresher herniation compared to that last disc that we just did, where it was pretty much older stuff. All right. Older herniation. Now this is gonna have to break it up with the laser because it's too big. Just doesn't want to come out. Now, Dr. Bernadette, you know that we're going to be moving towards the outer part, right? And at the end, that's where we'll be. So we probably got about 10-15 minutes left. Yeah. That's why I'm telling you. So you can get ready. Las Vegas cocktail, that's awesome. Go to it and grab it. Don't wait for it. Oh, there's a piece. No, I don't drink in Las Vegas, actually.
I'm sure.
But what are their big tall drinks?
Yeah, they're like this tall.
Oh, the yards? What is it?
Oh, I haven't seen them.
That's what the joke was applying.
No, there was a place called Tuesday Morning or something like that, or Fat Tuesday. Is that's more of a?
Tuesday morning is for buying pots and pans.
Yeah, no, Fat Tuesday.
You can't get a drink in there. Not that I'm aware of.
I'm thinking of Fat Tuesday.
It's Fat Tuesdays and Senior Frogs are almost the same.
Yeah, don't they have those giant drinks?
Yeah, they call it yards.
The yards.
The
Yeah.
Yeah, they're colorful. Yeah, those are. Oh, they're dangerous.
I wasn't sure if you've ever been to the strip and watched people carrying them.
Hot
Because
tail
they're
is
pretty big
gonna be,
chore to
it's
walk
gonna
with
be
them.
in the next 15
I've
minutes.
been to the strip and I've walked along it, but I don't really see people drinking out there. I guess they are. You know, when I go to Vegas, you can find me in the restaurants.
Yeah, they're world famous.
I'm always trying to find a good place to eat.
I would break bread with you there.
Yeah, right?
It'd be
There's
fun.
some good restaurants. Gosh, I mean, I've been going to Vegas since the 70s, was a kid. And
So close.
yeah, well, my uncle gambled. My father once in a while would go there and gamble. But we lived in LA, and you know, that's the thing you do. You go to Vegas for vacation. Anyway, back then,
Take the interstate.
the food was free. Oh, there's a big herniation. That's finally we're getting it right there. That's it. All right, this is going to be a good one, guys, right here.
Tom, please.
Bam! Look at the size of that thing. There it is. All right, I told you we were going to get it. Can you see this, Flynn?
That'll be a game changer.
Look at that thing. Now that's the 7-month-old herniation right there. What? Right? So when this patient said his pain started 7 months ago, it's probably the one that started 7 months ago, you know? All right, very good. Yeah, when I was going to Vegas back in the 70s, 80s with my family as a kid, it was just, you know, everything was free.
Like $2 steaks, right? Or
Oh man, I mean, no, free. Like you could go and eat a buffet for free. Why? Because the casinos just wanted to attract people.
You're
Huh?
paying 800 for that meal.
Yeah, they want to attract people to gamble. The moment you walk into their buffet, you're in their casino. And then you'll stay and gamble.
when I moved there was $2 steaks.
Yeah.
That all day.
No, it was all you can eat buffets.
And $2 steak, yeah.
I will eat that all day.
I mean,
I tried not to go to the buffet so much because I suffer from chronic obesity. So
well, dude, you didn't suffer from chronic obesity when you were 10 years old, did you?
oh no, whatever.
You're talking about nowadays.
Yeah.
Oh yeah, I have the same problem. But no, back then you literally never paid for food. You just go there, eat, and it was kind of like that was the catch to get moms and kids, you know, families to come, was the free food. You know, once you get the whole family there, dad gambles the family savings away while mom and the kids, you know, eat.
Eating a $2 steak.
You go from buffet to buffet. And I guess nowadays it's just they've got so much business with all the international travel that they don't need American tourists as much, so they just jack the prices up. Now food is ridiculously expensive in Vegas.
That's probably
We're a little overexposed.
places to dine out.
Well, the only
Is
thing
it?
that's cheap is the hotels.
Are the hotels cheap?
And they're still
Yeah. On off season. But
Oh.
yeah.
I might be
Summertime
wrong.
you can get great.
We're overexposed, guys. I need this exposure down. Who's going to turn it down?
Yes. So yeah, there you go.
That's good. Thank you. The hand of B.
Oh, that's another one.
Oh, so annoying. All these little pieces of herniation, they don't want to come out. They just want to sit there and block my view. Get out of there, bum. All right, well, again, normally we'll take questions during surgery, but today we're not because our video audio system is down. Flynn, what are we doing to repair the audio system? Any idea? I know Troy was here last week. Huh? Oh no, it's supposed to be Henry who's out this week, so maybe you can touch base with Troy and find out. See the blurriness, Luis?
Yeah, I see it. I see it.
This is a problem.
Do we try to maybe wipe?
I'm gonna try to adjust something.
It's not wiping. Huh?
Little
Like another
darker.
adjustment or
No, it's not you. I think it's the scope or something. It's just not a crisp image like I'm used to seeing. This is going to get more and more stimulating the closer we get to the outer fibers. Motherfucker.
can I get another bag of fluids? Thank you.
Don't grab it that way. Oscar, please. No, you're grabbing the top. You're applying force here. You're supposed to only grab the side, okay? It's like, come on, man. I want to see you make some progress with your understanding of what you're doing. If you pay attention to Luis and watch every single movement he makes, he doesn't waste any time doing anything that's not supposed to be done. So if you study his moves, you'll understand. Then you just have to say, why does he do that? Why does he do that? Why does he do that? And ask yourself and answer it yourself. And if you still can't answer it, then you ask him. But you need to learn from watching him. You can't just make all the same mistakes he's made over the years and expect me to tolerate that. I don't tolerate it. Okay, I have too many other things to do that I have to teach you. You have to learn from Luis by watching him. Okay? You got to do what he does. You're not going to reinvent the wheel and be better than him today. So maybe someday when you master everything he does, then you can create something new that's different, that's better. But today, you need to do everything he's doing. Mimic it, learn it, and do it the same way he does it. Otherwise, you're falling short. Okay? Surgery is it's not like making a cheeseburger. Okay? It's not like, well, put a little ketchup today and tomorrow put a different amount and different pickles, different onions. It's got to be exactly the same way every time to get exactly the same results, the right result. If you start to vary the ingredients, okay, then you start to get a different outcome every time. And we don't want a different outcome every time. We want the same results every time. Five minutes max.
They all know? Huh? Okay.
What'd you say? Oh, Patel? Yeah. Yeah, okay, that's fine.
It's gonna be ultrasound,
Yeah, is he coming right now? All right, so Dr. Patel is going to be following me on this patient doing a piriformis injection. So that highlights a good point. This patient came from out of town, and we know for sure that he's got some bad discs that are causing pain, but we also know from examining him that he has what's called a piriformis syndrome, which is a torn muscle in his buttocks. It's not something that I do injections for, but it's something that Dr. Patel does injections for. And it's not the same as an epidural. Epidural is medicine going in where the nerves are. A piriformis is putting medicine in where the muscle in your buttock is torn. And so this patient's going to have a piriformis muscle injection with some medicine to reduce the inflammation from the torn muscle in his buttock. This is all looking really good. A lot of scar tissue here. This is certainly consistent with, 7 months or longer. Some of the scar tissue I'm seeing here has probably been there for years. I think this patient's back pain probably got aggravated 7 months ago, but I have a feeling he's had back pain for longer than 7 months. He said 7 months, but this disc is telling me a totally different story. And it's very common for people to have a herniation 10 years ago, have back pain, forget about it, it gets better on its own. Then they have another herniation 5 years ago, and then it gets better after a few weeks, and then have another herniation, another, and another, and another. And in the end, by the time I do surgery on people, they've had 20 or 30 herniations. And you can actually see every single herniation in there. And some of them I have to cut in half to get them out, but it's still you can see the herniations. 2 minutes. Just putting my finishing touches on this masterpiece. There's the epidural fat. Yeah, we're here. He's sleeping right through it, which is wonderful to see. Yep, I got about 1 minute. Just about done. Is he doing all right?
Yeah.
Patient's good?
Yep.
Thank you.
Blood pressure's good, everything's good.
This is the outermost part of the herniation. You can see the fibers there by the laser tip. That's the posterior longitudinal ligament. And this is all scarred in annulus from the herniation. So the nuclear herniation in the annular tear causes an inflammatory response, which you can see here is all this scar tissue and calcium. This is longer than 7 months. This is several years old. All right, I'm happy with that. Let's take a look to the right. Should be a nerve root out there. It's buried in fat, which is fine. We want to keep it that way. The nerve is supposed to be protected with fat. Fat does two things. It gives energy to the dorsal root ganglion, which is a highly... There's a piece of herniation that was hiding just under the top side. We're going to get that out and we're done, because I don't see anything else. All right, we got the irrigation. There we go. Let me see that one last. Don't twist it on my finger. Straight up. Okay, that's good. We're done.
Lights on, please.
If you have questions, feel free to type them up. I'll answer them for you face to face. Scope off, laser off. We're gonna put a little antiseptic. And you can kind of see, if you're watching here, Flynn, there's little pieces of herniation everywhere here. Why don't you show our audience a video that compares the Deuk laser disc repair to the fusion that this patient would have had to have had if he didn't have the Deuk laser disc repair to get rid of his symptoms.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
It's Dr. Deuk at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. and I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery, you've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too, when you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's going
Are we live? L4-5, L5-S1 Deuk laser disc repair. We're also doing a piriformis muscle injection. Just so you understand what that is, basically we're entering the patient's herniated disc, which is right here and right here. We're entering it from the side rather than the middle. Going through the middle, you have to remove all the bones and ligaments that stabilize the spine. By going around the side, you don't take anything out, it's just empty space. There's a little bit of muscle here and you go past the muscle. The surgery went very well. We found that those two discs were indeed causing his pain. He described it at a 9 out of 10 when we tested the disc for both discs, and concordant, meaning that's his typical pain. So now that the discs have been repaired, he needs to heal those discs. That takes about 9 months to 12 months, and he'll do fine. All right, let's take our first question.
The first question is from YouTube, and that was a question from the live stream earlier. It's from Metro Neuro and Spine Hospital. In a cervical disc, is there any criteria of disc height? If it's a collapsed disc, can we still do cervical disc repair?
Okay, hi there, Metro Neuro and Spine Hospital. Thank you for watching, and if you were watching our first stream, you saw that we had to abort the case after numerous attempts for me to get into the disc. And I'm going to show you why. I'm going to use not I'm not going to use a thoracic spine. I'm going to use a lumbar spine just because it's easier to see the anatomy. But I'm going to get there to answer your question in just a minute, but I want to talk first about that first case, okay? So this is the back of the spine. The patient's back is here. I have to go from out here past the facet joint, just past it into the disc. The problem with that patient that we had to abort, the facet joint was so arthritic and large, and you can't tell before surgery whether or not you're going to be able to get in. So you just have to try. And this joint had gotten pretty big and arthritic. It grew over here. So when I was coming in to get into that space, I was hitting that facet and it was pushing me lateral. So the tip of my dilator was actually outside the disc right here. And I could not get it into the disc, even though I tried different techniques. I tried coming from the top, I tried coming from the bottom, I tried coming more lateral. Whatever I tried, it didn't work. So that was a rare case of an aborted surgery because of abnormal anatomy that's so abnormal it wouldn't allow me in. When it comes to the cervical spine, the question really is centered around the disc again, and the question really is, do you ever get a disc that's so collapsed that you can't fix it with the Deuk laser disc repair? The answer is yes, but it's extremely rare. We can fix discs that are even 80% or 90% collapsed, and the reality is even though there's no disc material left between the vertebral bodies, the pain is still coming from the tear in the back of the disc and inflammation within that tear. So if I can still access the back of the disc through the disc, using my small dilator and tube, I'm able to debride that tear, get rid of the herniations. It doesn't matter if you leave it bone on bone like it was when you started. That's not what causes the patient's symptom. Patients have no pain or no problems from that. The problem literally comes from the annular tear in the back of the disc and the interposed nucleus pulposus, that's herniated nucleus pulposus within the annular tear, causing inflammation. So to answer your question, I have probably had to abort maybe 1 in 100 cervical discs that I'm trying to get through an anterior transdiscal approach endoscopically, because the disc is so collapsed. But if you watch all my videos, and they're all on YouTube, you could literally watch hundreds and hundreds of my surgeries. You'll see there's lots of patients with totally collapsed discs, but we're still able to fix their problem. Next question.
And then we had 3 questions asking the same thing. They were all on YouTube, and the questions were the recovery time for the Deuk laser disc repair compared to a traditional surgery.
Yeah, recovery time for Deuk laser disc repair is literally 1 hour. The patients cannot drive a car the same day, but they can drive their car the next day. They can go back to a normal life the next day. So whatever you consider the recovery time is typically the recovery period of time from the time surgery ends to the time the patient's stable for discharge from our facility. That's the recovery time. That's 1 hour on average. And we published that data back in 2012. If you go back to one of our original papers in Surgical Neurology International, it's free open access paper. You can read about it. I think the average recovery time was 53 minutes. The average operative time was 52 minutes, so both under 1 hour. And that still holds true for today. So when can people go back to a normal life? Literally the next day. A lot of people go back to work the next day as long as it's light duty. So I don't know exactly how you define recovery time, but we define the recovery time from the time of getting out of surgery to the time of discharge from our facility. All of these surgeries are outpatient. Nobody stays in-house, nobody stays overnight.
The next question is from 80 on Facebook, and she's asking, I had a fusion done yesterday in the hospital still. My right leg is now numb, like I sat on it too long, and it's tingly.
Ooh.
Can you tell me your opinion? It's my 3rd surgery.
Hi, 80. Wow. First question ever, I think, historically, from a patient who's still in the hospital after having a fusion. Wow, amazing. So happy to have you here with us. It's really cool. I'm so sorry your leg is numb and tingly, but it is concerning to me. That's not normal. Anytime I've ever done a fusion or any kind of surgery on the lower back to get rid of nerve unpinched, people don't have that numb, tingly feeling. It usually goes away right away. So that's concerning to me. And you're saying it's your 3rd surgery. Even more concerning that maybe the surgeon who's operating, and I don't know if it's the same surgeon for all 3 surgeries, but I'll assume it is, maybe that surgeon is not doing such a great job. That said, the kind of things that could cause a numb, tingly leg, there's several things, okay? One of them is you could have your fusion here, but there's another disc above or below your fusion that's bulging out, hitting the nerve. So the problem may not even be at the operative level. It may be the level above or level below if you've got a bulging disc there on your MRI scan above or below. I could tell you that if I had access to your MRI. I could look at it. I'll tell you if you have a herniated disc above or below. But let's assume for a moment you've got normal discs above and below, no stenosis above or below. Your problem's coming from the operative level. In that case, you know, it could be that the surgeon just stretched the nerve too much during surgery, like they pulled on it too hard, and that caused what's called a neuropraxic injury, which will heal over time as long as they didn't cut the nerve and they just pulled on it. It should get better. On the other hand, it could be a cage that's sticking back out, hitting the nerve, in which case you want a CAT scan or an x-ray that will show the back side of the cage so you know it's not anywhere near the nerve. It could also be the surgeon put the screw in and hit the nerve while they were putting the screw in, because the screws are right next to the nerve, so they could have damaged the nerve with the screw when it went in. It could also be there's a screw still sitting on the nerve that they didn't recognize, that they didn't do intraoperative monitoring with, you know, direct stimulation of the pedicle screw. So there's a lot of possibilities. I hope it's just some, you know, retraction, injury, neuropraxia to the nerve that's going to get better in time. But you won't know until you ask your surgeon. So my advice is talk to your surgeon, let him know, ask him if he wants to get any x-rays or a CAT scan. A CT scan would be the best way to find out if there is any ongoing compression of the nerve root by the hardware. That's the cage or screws. And then of course if there's residual stenosis, In other words, if they didn't treat the stenosis, which is entirely possible, I see it all the time, that's the number one cause of failed back surgery, is the patient still has stenosis after the surgery. It's just bad surgical technique. It's entirely possible, but I wouldn't know unless I see an MRI and CAT scan. So I can help you when you get out. As long as you send me your imaging, I'll look at it. But right now, the best thing you can do is talk to your surgeon, let him know you're having problems. Could also be a hematoma or a blood clot, like what's called an epidural hematoma. Could be pushing on the nerves from the back. If it's getting worse, you 100% have a problem that needs to be addressed immediately. So I would let your surgeon know. Thanks for typing in your question.
That was the last question.
Thanks for joining us. We'll be back for one more surgery in about 30 minutes. It'll be another lumbar Deuk laser disc repair on a patient with a herniated disc, a left L3-4